I'm Dr. Sara Sheikh. Hello, everyone. I'm Dr. Sara Sheikh. I'm MRCOG Part 1 mentor with MedPrep Online. And today we'll be having a discussion on a very important topic, which is physiology of pregnancy, all the normal adaptations that we see during pregnancy. So I hope you all have registered for your MRCOG Part 1 and you will be showing your, giving your expression of interest and accordingly preparing for the exams. So physiology per se is a very important module from MRCOG point of Part 1 point of view. And with having said that, one of the most important topics is pregnancy physiology. So pregnancy, as we all know, the changes that occurred in the body, they are in a continuous as well as in a dynamic state of change throughout all the trimesters. So pregnancy itself is a hyperdynamic condition. It is a hypermetabolic condition because of the increased demands that the mother has to meet with regards to the fetus, the growing baby, and it's a hypervolemic state. There is hypercoagulability. There is a hypertensive state as well as a low vascular resistant state. Now, as we can see from this picture, in spite of having all of these adaptations and all of these changes taking place, most of the pregnant individuals, they end up going through an entire pregnancy in an uncomplicated manner. And we do not see much of pathological changes. So we need to know what is abnormal during a pregnancy so that at the right time during our practice, we will be able to pick up what is abnormal, what is an abnormal adaptation, right? So these things are very important from your clinical point of view, as well as important for your SBAs for MRCOG Part 1. So this forms your basics of physiology as well as the pathological changes and all your diseases that we'll see in pregnancy. So we'll start with what are the basic changes you see in a pregnant woman. You will have in the first trimester a woman coming to you with certain common signs and symptoms, like they may have certain food aversions, they'll have nausea as well as vomiting of pregnancy, they'll have facial edema, edema of the hands and feet because of water retention, right? There'll be some amount of weight gain and puffiness. They'll come with back pain, as we call it lumbar lordosis, and there'll be change in the taste buds. All of these we can attribute it to the changes in the hormonal milieu, right? Because of the increase in the level of estrogen, progesterone, human chorionic gonadotropin, all of these will have certain effects. Now, what are the most important physiological changes from your practice as well as from your exam point of view are the changes that we see in the major organ systems, like the cardiovascular system, the respiratory system, the hematological system. So we need to understand why these changes take place, right? So first of all, you have to know that we see changes in almost all the organ systems, but we have grouped them into what is important that we have to know. So gastrointestinal, what you need to know is because of the changes of the hormone levels, you will have patients coming with decreased bowel motility, and that may lead to constipation. This is primarily because of the relaxing effect of progesterone as well as the hormone relaxin, which is secreted, which will act on the GIT, right? It'll act on the smooth muscle and this will delay the gastric emptying. So patients will come to you with even complaints of heartburn. Why that happens is because of the same effect of these hormones on the lower esophageal sphincter. So this will cause heartburn. So all of the pregnancy changes that you see, they have an underlying correlation. It has a physiological reason to it, right? So in the renal system, there is an increase in plasma flow, the filtration rate increases, and consequently, you will see when you have a patient coming in with some reports, like a renal functional test, you will be able to evaluate their serum creatinine is lower, the blood urea nitrogen level is lower. So you may think it to be pathological, but once you know the reasoning behind it, we know that these are normal physiological changes in pregnancy. So your parameter or your bar is set at a higher grade to know if the creatinine is raised, right? Now, for endocrine, we know that the demands of the fetus, the metabolic needs of the body are increased in pregnancy, due to which there is an increased need for the levels of thyroid hormones, right? So your T3 and T4 production is increased as well as the demand. If it's not met in a patient who has pre-existing thyroid abnormality, that may lead to exaggerate the hypothyroidism and may also lead to deficiency for the fetus, right? So it can lead to thyroid deficiency in the fetus. So all of these things have to be correlated in your practice, and that is why physiology of pregnancy becomes a very important topic. Now, the most important systems that we will be discussing in detail, as I said, are cardiac system, the pulmonary system, and the hematological system. So we'll be covering them one by one, and we'll begin with the most important, the cardiovascular system. Now, why do I state this to be the most important of them all? Is because the most important and the most direct cause of deaths, maternal deaths in UK, as per the recent MPRACE reports, that is 2019 as well as 2023, has been cardiac disease, right? So all of the physiological changes that occur in the pregnant individual, if the mother is a healthy individual, she ends up coping well with all of these adaptive mechanisms. But if there is any underlying pathology, or if the mother has any underlying cardiac illness, then these may get unmasked during pregnancy as well as the immediate postpartum period. And this is a major contributor towards maternal death, right? So heart disease, it can occur even for the first time in pregnancy. So there are some certain flag signs like severe chest pain and breathlessness during rest. So some amount of dyspnea while working is normally seen in all pregnant patients, especially during the later trimesters. But breathlessness while resting is an ominous sign and has to be investigated, right? And especially when lying flat. So any dyspnea that the patient gets during resting, or any orthostatic or postural dyspnea, has to be investigated, right? And who are at more risk of having such diseases are women who are older, if they're obese, if they have certain comorbidities like diabetes or hypertension, if they have a family history of heart disease, or if they are smokers, right? So according to the Embrace 2023 report as well, after COVID disease has been excluded, cardiac disease has still been the highest ranker amongst the causes for maternal deaths. Now, coming to certain definitions that we need to know once we proceed with the study of the cardiovascular changes is what is stroke volume. So going back to our basics from our medical days, stroke volume is the amount of blood that is pumped by heart in one contraction, right? So stroke volume of both the ventricles is the same. It is around 70 ml in a non-pregnant healthy individual. And this is loosely the term is used, and it is applicable for both the ventricles, right? The amount is also calculated by calculating the amount left from subtracting the end systolic volume from the end diastolic volume, right? So end diastolic volume minus the end systolic volume will give you the stroke volume, right? Now coming to the cardiac output. The cardiac output is the amount of blood pumped by the heart in a minute. So cardiac output is calculated by multiplying the heart rate per minute into the stroke volume. The central venous pressure is the measure of the pressure in the venae cavae, right? So it gives you an estimate of how much preload is there, how much blood is there in the vascular system, as well as the right atrial pressure. Now, the systemic or the total peripheral vascular resistance is the amount of force which is exerted on the circulating blood by the vasculature of the body, which is the arterial system of the body that exerts a certain amount of pressure onto the flowing blood. So this is the pressure against which the blood has to be pumped, right? Now, coming to the cardiac changes, most importantly, for MRCOG Part 1 exam, the questions are asked with regards to what parameters and how do they change. So these have to be learned by heart. You should be able to answer this from the top of your head. So always memorize this chart, have it pasted onto your stick-on, but just keep in mind what is raised, what is lowered, and what remains unchanged. So heart rate, as we saw, increases, so around 10 to 15 beats per minute from the resting heart rate, so around 80 to 90 beats per minute. Stroke volume is increased, cardiac output increases. We'll discuss about these changes in more detail. What goes down is because of the relaxing effect of progesterone as well as other hormones in the body. There is stimulation as well as dilatation, and you'll have systemic vascular resistance will fall, right, because of your arterial vasodilatation. Along with that, the peripheral vascular resistance, and corresponding to it, the systemic as well as the systolic as well as the diastolic blood pressure will fall. What remains unchanged is the central venous pressure, the pulmonary capillary wedge pressure, as well as the colloid osmotic pressure or the oncotic pressure in blood. Now we saw that the cardiac output starts rising. So because you have to increase the blood flow to the growing fetus as well as the placenta, the demands of the body increase and the blood volume increases, right? So as the blood volume increases, we can see the cardiac output is also increasing because the stroke volume as well as the heart rate. So both the components that comprise the cardiac output are increased. So consequently, we see a rise in cardiac output right from 6 to 8 weeks of gestation, and it goes on to increase to reach its max. So the maximum that we see is immediately postpartum. So it is the highest during the second stage of labor and immediate postpartum period, wherein it is almost 50 to 60% of the non-pregnant or pre-pregnancy values. So these are certain high risk areas for decompensation, wherein if a patient has a pre-existing cardiac illness, this may get unmasked. Patient may develop pulmonary edema or heart failure, right? So around 12 to 6 weeks of gestation, because it is the beginning of the hemodynamic changes, it peaks at around 32 weeks, especially during the second stage of labor and delivery. Immediately postpartum, immediately post-delivery is the maximum risk, and 4 to 5 days postpartum. So once the delivery, after the delivery, what happens is the cardiac output comes back to normal. So it reaches the pre-pregnant values. It reaches at least the pregnancy values within 2 to 3 hours. But to reach the non-pregnant values, it takes around 2 to 6 weeks postpartum. So again, we saw the cardiac output the increase is almost to the count of 40%, which is from 4.5 liters. You can say an added 1.5 liter is increased, right? So up to 6 liters per minute. So 4.5 to 6 liters is the range. Always remember that in RCOG, you may not get the absolute values. So the range is 30 to 50% increase in cardiac output. As we saw, the plateau is around 24 to 32 weeks. The maximum cardiac output is seen in the second stage as well as the immediate postpartum, and it falls again by 6 weeks. The stroke volume is increased by 30%. There is almost a 10% increase in heart rate to the count of 80 to 90 beats per minute. The oxygen consumption to meet the growing needs of the baby, the metabolic needs, the oxygen consumption is increased to around 30 to 50 ml per minute. Because of the fall in systemic vascular resistance, we'll see that the blood pressure is also reduced. So because of the relaxing effect of progesterone on the arteriolar dilation, you can see that the fall is almost 35 to 40%, and this will normalize 2 weeks postpartum. Systolic blood pressure remains more or less stable throughout pregnancy. The fall is only around 5 millimeters mercury during the second trimester, whereas the fall in diastolic blood pressure is more marked to the count of 10 millimeters mercury. And always remember the lowest point of the nadir is at around 24 weeks. Again, this normalizes close to term. So the systolic as well as the diastolic pressure is usually normal by the end of pregnancy. The plasma volume increases to about 45%, which is an extra 1.5 liters. And the red blood cell mass or the erythropoiesis is increased to the count of almost 20 to 30%. So now we'll see what are the effects of these. Also, what you need to know is because of the growing pregnancy and because of the anatomical remodeling and all the spatial organization of the organs in the chest, there are certain changes that you will see in the anatomy, which will reflect in the ECG, right? So certain points that you should know, which are seen in normal physical examination in pregnancy, are a systolic ejection murmur, and this is because of the turbulent blood flow, because of the increased amount of blood which is flowing through the both aortic as well as pulmonary valve, right? So there is enhancement of the first heart sound. You can also encounter splitting of the first heart sound. There some amount of tricuspid regurgitation as well as pulmonary regurgitation is normal in pregnant women. Around almost 1/3 patients you might even find the regurgitation in pulmonary as well as tricuspid. Few patients may even develop some amount of mitral regurgitation. You can even encounter S3, loud S3 and S4 sounds. Now in the ECG, there's also persistent splitting, right? Towards the end of the second and third trimester in the last 10 to 14 weeks, there is also splitting of the second heart sound into the pulmonary and the aortic component. And around 90% of patients, you may encounter a mid-systolic murmur, which is present on the left sternal border. This is because of the increased blood flow, which is ejected from the pulmonary valve into the pulmonary trunk, as well as from the your aortic valve to the brachiocephalic arteries. Now, what are the certain causes? The cardiac output increasing will lead to hypertrophy. Obviously, because of the increased workload in the heart will hypertrophy, and along with the hypertrophy, you will find some amount of atrial as well as ventricular dilatation. So how is this reflected onto your ECG? You may find Q waves, which you will see in lead 3 and AVF. Then you may find inverted T waves in lead 3. Because of the increase in heart rate, it predisposes patients to developing atrial ventricular ectopics, as well as some cases of you might even encounter supraventricular tachycardia, right? So all of these points are very important and frequently asked questions in what are the normal findings in ECG, as well as what are the normal cardiovascular changes that you see. So because of the enlargement of the heart, there is displacement of the heart more anteriorly, right? And there is a shifting of the axis. So during the first trimester, there is a slight right shift, but always remember for the broader picture, the heart mainly shifts. There is a left axis deviation, right? So it's more like to the anterior and to the left. So there is a leftward shift in the axis. There can be possible depression of the ST segments as well. And like we discussed, inverted T waves and Q waves. Now coming to a very important part of cardiovascular system is the supine hypotension syndrome, or which we also call it as the postural syndrome, or the Menger syndrome, or inferior vena cava syndrome. So basically what happens is, because of the growing fetus as well as the weight of the gravid fetus, gravid uterus, this presses on to the inferior vena cava, against the spine of the woman when she lies in the supine position. So this curtails the blood flow back to the heart, which in turn reduces the cardiac output. Because of the decreased cardiac output as well as a fall in blood pressure, patient may complain of fainting or giddiness or syncope, right? So this is mostly seen in later trimesters. Almost 10% of women encounter this condition in later trimesters in supine position. So because of the decreased venous return and cardiac output, the fall in BP may result in fainting. And why this occurs is because the normal compensatory mechanism is not up to the mark. So there is a failure of formation of collaterals, the paravertebral as well as the azygous veins. And how do you treat it? Simply, you put the patient in a left lateral position, and even by elevating the mother's hips by 10 to 15 centimeter, right, you can put a wedge between below the mother's hip, thereby elevating the right hip of the mother, and this will relieve the compression on the IVC and increase the cardiac output or the venous return back to the heart. So during labor, this is also may be encountered in labor, but usually it doesn't appear so, because along with, in spite of being in supine position in labor, still there are contractions, right? Uterine contractions, which forcefully pushes the blood back into the cardiac system, the venous blood back to the heart. So in a way that is protective, but what we need to be mindful of is this may cause certain adverse events during C-section. So during cesarean section, when the patient is in a supine position, especially under spinal anesthesia, as we know, spinal anesthesia in itself causes some degree of hypotension. So there can be sudden and severe hypotension, and this will be detrimental for the fetus, because ultimately it reduces the cardiac output of the mother, it reduces the blood going through the placental circulation to the fetus, and can impair the fetal oxygenation. Now coming to hematological changes. So what changes do we see, and more importantly, why? Firstly, it is to increase the blood supply. So all of the blood volume that is increasing is to increase to meet with the demands of the growing baby. So to increase blood supply to the uterus as well as the growing baby, to compensate for the impaired venous return because of the gravid uterus, which we just discussed. Also to increasing the blood volume to compensate that for the blood loss that the mother will encounter during a miscarriage or a delivery, right? And to increase the fetal red blood cell mass. So what are the most significant adaptations that we should know of? Physiological anemia. There'll be some amount of leukocytosis with specifically neutrophilia. As we discussed, pregnancy is a procoagulant and a prothrombotic state. So there will be increased in the procoagulant factors. Mild thrombocytopenia, which is called as gestational thrombocytopenia, is also observed, and there'll be diminished fibrinolysis. So all of these are protective mechanisms, firstly to nourish the mother and the baby, as well as to compensate or to reduce the blood loss during delivery. So all of these mechanisms have been evolved naturally so as to, because as they are protective for both mother and baby. Now, why do these occur? We'll go through them one by one. So as in pregnancy, the renin level rises and the atrial natriuretic peptide level falls. There is also an increase in nitric oxide as well as prostaglandin I2. All of these have a relaxant effect on the vascular system. So there is systemic vasodilatation and the vascular capacitance increases. But if there is increased vascular capacitance, but the blood volume, if it doesn't increase significantly to match up with the capacitance, there'll be an underfilling of the entire arteriovenous system, right? So along with that, there is an increase in blood volume. Now, what happens at the same time is there is a stimulus to the erythropoietin production in pregnancy because of the hormonal effect of all progesterone, right? And as well as human placental-lactogen. All of these things will lead to a stimulation of the renal erythropoietin, and there will be an increase in the red blood cell. There will be an increased production of RBCs. But this production of RBCs, it does not match, or rather the increased blood volume, it is much more significant than the RBC mass. So because of the increased blood volume, there is a kind of a physiological or a dilutional anemia that develops, right? So this is seen maximum at which peaks around 32 weeks of gestation. So because of the increased erythropoiesis, there is also an increased demand of iron in a pregnant woman. So iron requirements drastically increase during pregnancy, and if the mother is not having enough iron stores in the body to replenish the losses, then there may be unmasking or there may be iron deficiency anemia, which may occur during any of the trimesters. So total iron requirement is of the order of 1000 milligram, and this is split into the follows. So 500 milligrams is almost required for the red cell production. There is 300 milligrams which is taken up by the fetus as well as the developing placenta, and 200 milligrams is required for the normal daily excretion through the body. So that is extra requirement of 4 milligram per day. So normally what you require is 2.8 milligrams. So in total, what a pregnant woman requires is around 6.6 milligrams per day of oral iron, right? So if these demands are met by your diet, if your diet is well replenished in all of the heme sources of iron, then a woman will not have to take any additional supplements or may not develop any iron deficiency anemia, right? To cover or to basically compensate for this physiological anemia. So now coming to the important definition of anemia and pregnancy. So whatever parameters we see in a non-pregnant woman have to be modified in case of pregnancy because of the effect of physiological anemia. So in first trimester, a hemoglobin of less than 110 grams per liter. In second and third trimester, I'm sorry, that is third trimester. So second and third trimester is less than 105 grams per liter, but postpartum is less than 100 grams per liter, right? You will also see that the serum iron levels, they go down, which is almost less than 12 millimole per liter. So these are not absolute values, but ranges that you have to remember. And the total iron binding capacity can reduce to less than 15%. So again, with hematological changes also you need to remember, and these are common exam questions about what goes up, what goes down, and what doesn't change. So once you know the physiology behind it, you do not need to muck them up. So as we saw, the blood volume increases, the plasma volume increases, the red blood cell mass increases to almost 20 to 30%. There is leukocytosis. Along with that, some amount of neutrophilia. The fibrinogen increases. So fibrinogen activity increases, but there is a decrease in the fibrinolytic activity. So all of these are to make sure to basically maximize the chance of clotting. So as to decrease the blood loss during delivery. Clotting factors are increased, especially factor 8, 9, and 10, right? Now, what doesn't change? Let's go to what doesn't change is the mean corpuscular volume, the mean corpuscular hemoglobin concentration. APTT may sometimes go down because of the affection of factor 8, but usually remains unchanged. The bleeding time and the prothrombin time also remains normal. Now, because of the dilutional anemia, the hemoglobin concentration decreases, right? As we discussed, it goes lower than 11.5 grams per DL. Then the hematocrit becomes lower than 30%, and the red blood cell count may also go down. Platelet count towards the end of gestation may decrease, and this is, like we discussed, is gestational thrombocytopenia. So you may have a lower platelet count, around 10% lower of normal. And what you see in circulation are the megakaryocytes. So there is immature platelets in the circulation, and this is physiological. And what you also see is lowering of antithrombin levels. So the protein S, antithrombin levels will decrease, the blood viscosity will also go down. Now coming to the last, which is the respiratory system. So respiratory system, mainly the adaptations that take place in pregnancy, what you have to remember is the mother needs more oxygen. So more oxygen has to be supplied to the baby. So how the adaptations occur are by increasing the rate and depth as well of a respiration, right? So that is when the oxygen carrying capacity of the blood is increased, and more oxygen is supplied to the fetus. So there is more gaseous exchange. So all of this is to maximize the gaseous exchange which is occurring at the maternal fetal interface at the placenta, right? So more oxygen has to be supplied to the fetus and more CO2 has to be removed. So how this occurs is there is an increase in estrogen as well as progesterone. So what this does is the receptors which are present in the brainstem, they are sensitive to the levels of carbon dioxide. So all of this will increase the CO2 sensitivity in medulla oblongata at the thalamus and hypothalamus level. Along with that, they will also increase the consumption of oxygen, right? So because of which there'll be increase in the minute ventilation as well as the tidal volume. So the amount of air that is breathed in and breathed out, as well as the rate and depth of inspiration will increase. This will lead to an increase in arterial PO2 and a decrease in arterial CO2. So this is more like a hyperventilatory state, whereas there is a CO2 washout, but the arterial saturation, that is PaO2, will increase so as to supply more oxygen to the fetus. So there'll be reduction in the lung volume. So the functional residual capacity of the lungs will also reduce. And if there is any underlying respiratory illness, that may get unmasked because of the increased load on the respiratory system to meet the oxygen demands of the body. So now coming to a few definitions that are important from physiology point of view. So you have tidal volume, which is the normal amount of air which you breathe in and out per breath. That is what we call as the tidal volume, which is increasing in pregnancy. Now, inspiratory reserve volume is the maximum amount of air that you forcibly inspire over and above the tidal volume. Same goes for expiratory reserve volume. It's the maximum amount of air that you can forcibly push out after the tidal volume. Now, the vital capacity is again a maximum amount of air that you exhale after a maximal inspiration. So this is a calculation, a summation of all of the above, which is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. Now, residual volume, as the name suggests, is the amount of air which is left in the lungs after a maximal expiration. And the total capacity, lung capacity, is what you get is when you add all of the above. So 6,000 is what you see is the total lung capacity at rest, which is mildly reduced in a pregnant woman because because of the anatomical changes, because of the gravate uterus and the diaphragm being pushed up and the lung capacity is decreasing, right? So now what are the changes we see? The mucosal edema in the upper airway. So because of this, because of the hormonal effects, because of the water retention, because of the edema of all of the tissues, there is a greater resistance to airflow. Now, how this becomes clinically significant is ventilation, bag and mask ventilation, as well as intubation may be difficult in pregnant patients, right? There is also a greater risk of airway obstruction with sedation. One important point I would like to discuss here is pregnant patients, because of the relaxing effect of progesterone on the lower esophageal sphincter, they also have a delayed gastric emptying and they have a higher chance of aspiration of gastric contents. Now, because of the gastric contents are acidic in nature, this becomes very important during anesthesia. So if there is any aspiration, this may lead to chemical pneumonitis, right, which we call as the Mendelssohn syndrome. So this can prove to be very fatal. So all of these physiological points have to be remembered so as to be able to manage the patient properly, right? So now coming to anatomical changes, you will see the diaphragm is pushed up by 4 centimeters, and this is because of the effect of the gravid uterus. The diaphragmatic excursions, because of the relaxing effect of all of the ligaments, you can see it is increasing by around 2 centimeters. There is expansion of the rib cage. The subcostal angle is increasing from around 68.5 to 103.5, and the dead space also increases by 45%. Now, the compliance of the lung remains unchanged, but it's the chest wall compliance which is decreased. Why? Because of the increase in the fat deposition as well as the abdominal contents. Now, the resistance in the initial phases, there is increased resistance, but later, because in the latter half of the pregnancy, the resistance to airflow will decrease, right? There'll be more and more efficient ventilation so that the mother will be able to breathe properly as well as be able to supply oxygen to the fetus, right? So along with the increased oxygen consumption, there'll be decrease in the resistance so as to maintain comfortable breathing for the mother. So the breathing in a pregnant patient is more abdominal than thoracic, and throughout the pregnancy, in spite of all of the changes in the volumes, that is the lung volumes, the FEV1 upon FVC, right? So the minute ventilation that we see, the flow rate, the expiratory flow rates also remain stable throughout the pregnancy. So the lung volumes that you need to remember are what increases, what decreases, and what remains unchanged. So respiratory rate overall remains unchanged, right? So inspiratory capacity is increased. The minute ventilation is increased by around 40%, as well as the tidal volume is increased by 30 to 50%. So common mnemonic to remember is I see movie in a TV, right? And what decreases are the residual volume, the expiratory capacity, because of which the expiratory reserve volume and capacity both are decreased, the residual capacity as well as the total lung capacity. So all of these will decrease. You don't have to remember the absolute values, but you should always remember which parameters are increasing and which are going down, because these are common questions in your exam. So REFT is the mnemonic to remember what decreases during pregnancy. So that is residual volume, expiratory capacity, functional residual capacity, and total lung volume. Now, as we saw, there is an increase in oxygen. So your arterial oxygen increases, but the PaCO2 level goes down, right? And because of a compensatory mechanism, this is a state of metabolic respiratory alkalosis. So there has to be a compensatory metabolic acidosis. So there's an increase in the serum, in the bicarbonate excretion by the kidneys, because of which the serum bicarbonate levels go down. So the levels are of the order of 19 to 20 milliequivalents per liter. So oxygen carrying capacity in the blood increases. So the consumption is rises to almost 50 ml per minute at term. The erythrocytes will produce higher levels of 2,3-DPG. So one important fact about 2,3-DPG levels is because of the higher production of 2,3-DPG, there is an increased oxygen letdown. So easily the oxygen affinity is reduced, and this oxygen can be easily transferred to the fetal tissues. And the P50, that is the partial pressure of oxygen, at which 50% of hemoglobin is saturated, that remains normal, right? And this is compensated by, because even after an increase in 2,3-DPG, there is alkalosis, right? So all of these will balance out, and because of which the P50 value remains the same. So these are the vital capacity, the lung volumes that you have to know. So spirometry graphs are very important during the exam. They can mark at any of the graphs and ask you to identify it. So we have seen through the diagram, we can see what all parameters are increasing, right? So the lung capacity is decreased, the vital capacity remains unchanged, right? The tidal volume is increasing, and here the functional residual capacity is reduced. So in ABG, what parameters you should look out for? So like we discussed, it's a slightly alkalotic state. So the pH is almost around 7.40 to 7.45. The PaO2 increases 104 to 108. PaCO2, always remember, goes down. So if you're not given any values, reference values in the ABG, please learn to identify that the PaCO2 in pregnancy is much lower, right? It is 27 to 32. Now, the bicarbonate levels, because of the compensatory metabolic acidosis, there is an increased excretion like we discussed, and the bicarbonate levels go down. Now, coming to the oxygen hemoglobin dissociation curve, there is an increased level of 2,3-DPG, right? And this releases, there is a decrease in oxygen affinity, so there will be an increased oxygen unloading. So this increases the release of oxygen to the fetal tissues, and this will cause, in spite of it, like we can see here, that the rightward shift is mostly seen when there is an increased PCO2. So in this case, the PCO2 is decreasing, but because of the increased 2,3-DPG levels, there is a rightward shift. So always remember, even if PCO2 is low or the pH is increased, it does not constitute a leftward shift in the oxygen hemoglobin dissociation curve. This is a very common confusing point. So just remember, because of the increased 2,3-DPG, which basically decreases your oxygen affinity and increases unloading, this compensates for it and causes a rightward shift in the dissociation curve. Now, coming in short to the renal system, what we see is the increase in the blood flow because of the increased plasma volume and increase in the total blood volume. There is also an increase in glomerular filtration rates. The blood flow to the renal system is increased. The glomerular filtration rate is increased, can almost reach up to 170 ml. So because of this, the output also increases. There is an increase in urinary frequency as well as towards the end because of the presence of the gravid uterus, right? The relaxing effect of progesterone also acts on the ureters, and this will cause hypomotility, right? In both the cases, what happens is there is an increased chance of urinary stasis. So such women are more prone to developing urinary tract infection, and because of the hypomotility and because of all of these changes occurring, there is a chance of developing pyelonephritis as well. Because of the increased blood flow, because of the hypertrophy, there is also almost a 1 centimeter increase in the kidney size. There is dilatation of the calyces, the pelvic calyceal system, and you may see physiological hydronephrosis. This because of the increased size of the gravid uterus, because of the backflow, this may cause increase in the size of the ureters and lead to hydroureter. So hydronephrosis as well as hydroureter may be normal physiological adaptations seen in pregnancy. So increased risk of UTI, like we discussed, it may also lead to pyelonephritis in a pregnant patient. Increase in the glomerular filtration rate increases the amount of glucose and protein excreted in urine. Because of the increased filtration rate, some amount of drugs which have a renal excretion may be excreted in greater amounts, which will reduce the therapeutic drug level. So this is important when prescribing drugs to the pregnant patient. So here we saw the renal blood flow increases. There is a plethoric swelling of the kidney, so 1 centimeter almost increase in size, increase in the filtration rate, which is almost 50% more of the pre-pregnant levels. Glycosuria, increased bicarbonate, which is metabolic acidosis, which is compensatory, like we discussed. And the net effect of this is because of the increased excretion of the sodium ions as well, there is a drop in the plasma osmolality. So usually what we see around 280 to 290. So this will be around 270 milliosmoles per kg. So your plasma osmolality is reduced during pregnancy. And in endocrine function, as we saw, there is increased renin production, which causes a relaxing effect on the arterial system. There is increase in the erythropoietin level, which increases the RBC mass. And there is vitamin D, active vitamin D absorption and secretion, right? So here we can see because of the net effect, there is also dilatation of the ureters, and the pelvic system is dilated more on the right than the left. So this summarizes all of your physiological changes that we see in pregnancy. And if you all have any questions, I'll be welcome to take them now. You can also type in the chat box. I hope this simplified the topic for you all a bit. And I hope it is easy for you to correlate now when you start your preparation. So always, whenever you're preparing for your MRCOG, please try and clear all your concepts first, because those are the basis for solving your SBA questions. So there are certain topics like physiology of pregnancy, right? And in other modules like anatomy, endocrinology, you have to know the basics really well to be able to answer all of your questions on clinical management and data interpretation. All right, I hope you all find this lecture useful.